Welcome everyone. My name is Ruiz Pozuelo. I am a PhD student in the psychiatry department at the University of Oxford. And I'm also part of the Mind and Behavior Research Group, which brings together development economists, psychologists, and psychiatrists to research topics at the intersection of development economics and psychology. So it's really a very great pleasure to be here, joined by three speakers that have devoted their lives to studying mental health from three different angles. So our first speaker will be Victoria Baranov. She's an associate professor of economics at the University of Melbourne, where I believe it's now 11 p.m. for her. So big thanks to Victoria for being so flexible. Her research explores how health, psychological factors, and norms interact with poverty and economic development. Victoria was also part of one of the world's largest psychotherapy interventions, which dramatically reduced maternal depression in rural Pakistan. She just recently actually published a paper looking at the long-term effects of this one-off intervention, and she's also looked at the effects on economic outcomes and the impact of the intervention on the children of these mothers. Our second speaker is Crick Lund. He's a professor of global mental health and development at King's College London and the University of Cape Town. Crick trained as a clinical psychologist and was involved in developing post-apartheid mental health policy and service norms in South Africa. He's also worked for the WHO and has consulted several low and middle income countries on mental health policy and planning. His research interests lie in mental health policy, service planning, and the relationship between poverty and mental health in low and middle income countries. The third and last presentation will be by Miranda Wolpert. Miranda is the head of the mental health priority area at the Wellcome Trust. It's a program that is determined to transform how we understand, how we fund, prevent, treat depression and anxiety among young people. Miranda is also a professor in evidence-based research and practice at UCL, and she's a world expert on child and adolescent mental health and was recently awarded an MBE for her services to children and young people's mental health. More specifically related to this event, Miranda is also part of a much-needed initiative led by the Wellcome and the National Institute of Mental Health in the US to harmonize mental health measures. But I'm sure she'll talk more about this in her talk. So thanks again to the three of you for being here with us. And Victoria, the floor is yours.
Great. Thanks, Julia, so much for the introduction and also for the invitation. I'm really honored to be here and excited to be part of this panel. So what I was asked sort of to talk about for this was about running and conducting mental health interventions and running these large trials. And of course, I have the caveat, which I actually haven't run many of these myself. My strategy has always been to partner with global mental health teams, which involve clinical psychologists, epidemiologists, and so forth. These large global mental health teams who already had planned or ongoing interventions that they were running and working with them. An alternative option for economists who would be interested in running, large trials would of course be to try to do something on your own, and a lot of folks have already done that. For example, Johannes Haushofer, of course, comes to mind because he's evaluated the PM Plus here, and these are based on manuals that have been published by the WHO, and so the WHO has several manuals. One which is PM Plus, which is a generalized sort of depression or mental health intervention. Other types of manuals that are available include cognitive behavioral therapy for perinatal depression. And so this is actually one that I was part of evaluating in the long term that Julia had mentioned. So I'll just say briefly, since I went the route of going with partnering with the interdisciplinary teams, like what are the pros and cons of that? I think the pros are that you get to work with a large interdisciplinary team, which is good because you learn a lot from that team. You have a lot more expertise, which is really needed. I think these interventions are hard to run, but one of the bits of it, I think that's important for economists is that there's a lot more quality control. So when you have, a team who is trying to publish in the Lancet, in medical journals, there needs to be a very sort of high bar of, checks on fidelity and so forth for the intervention. I think things that don't necessarily happen in such a rigorous way in general for econ. And so this is one of the things that I think happen with partnering with these teams as well, is that you, in general, probably will have a better run intervention. I think a con for economists would be that you have a large interdisciplinary team, which means that you sort of have to negotiate what's part of the intervention. You might not have the final say. And then you have a lot of people who have, things that they want to include in the questionnaire and the follow-ups, etc. Survey fatigue starts to play in. So there's, you can't get everything you want with these. But I really enjoyed working with the mental health, global mental health teams that were working on these projects. One of the main issues, I think, with running these large trials is that, we have a lot of evidence on effective interventions that were carefully designed and monitored and actually appropriately targeted towards particular participants. So here's an example. I think the one from my own work is, Thinking Healthy program, which is cognitive behavioral therapy targeted towards women who are depressed around the time of pregnancy. And so this is a depression intervention, but it's not just for anybody who's depressed, but really targeted towards women who are depressed around the time of pregnancy, which is a very specific sort of set of people with specific needs. And so the intervention, I think, works really well at scale, or can sort of scale because of that. But once we start to broaden the subject pool to say anybody who might be depressed for whatever reason, or we start reducing the skill level of the therapist, for example, if we're going from community health workers that are trained to provide the intervention to, say, peers, I think what we've seen is a dramatic effect and a reduction in efficacy. And so scaling up with these mental health interventions, I think, has been the major challenge and one of the sort of issues in translating some of the work that's been done by sort of the clinical teams into what economists kind of want to use in their work. And sort of as a final note, since obviously this is on measurement, and Crick is going to talk a lot more about this, and Miranda as well, on harmonizing, but I'll say this from the economist's perspective, and I want to highlight, sort of two different types of measurement. And in terms of measuring mental health, one that's quite common are depression or mental health screeners, which are screening for, whether someone is depressed or has anxiety, etc. So common ones, PHQ-9 and CSD for depression. And here with screeners, these are not clinical diagnoses. And so if you have a screener as something that is an outcome, you can't say that, this intervention reduced clinical depression rates by X%, because there's false positives and false negatives, etc. There's also other issues around, these types of these screening questionnaires. They're subjective, and I think culture affects the reporting. And there's a lot of sort of studies into this. And these measures, for example, the PHQ-9 has been validated in many different places. But then if you look into the validation studies that actually, measure PHQ-9 and clinical diagnosis, you'll see that these are actually quite small studies and really non-representative samples. So for example, the India PHQ-9 validation might be from, or for whatever country you might be in, might be from urban, educated, high income population, and then you trying to take this measure and put it into the rural setting. It's going to be completely different, behave completely differently there. And so I want to highlight that the screeners are not the same thing as clinical diagnoses, which you could get if you sort of can train your enumerators to conduct, so for example, the semi-structured interview for depression, the SCID. So these are alternative measures that can be used, and the clinical diagnosis is obviously less subjective, but there's still measurement error because you probably, that's going to happen. It's still somewhat subjective, I think. So one of the things that I have done in my research has been to try to get another measure that's less less subjective. And so what we've done is collected biomarkers of the HPA axis, which is thought to be involved in depression and it's a dysregulation of the HPA axis. And so you'd be familiar with the stress hormone cortisol, but also DHEA is also thought to be involved. And so you can potentially measure sort of these biomarkers using saliva, which would measure acute output from the HPA axis, so like the last hour or so. And from hair, you would get something like chronic output up to about 6 months. So here's an example of hair collection. And with hair, as opposed to saliva, it's really easy to store, although it's more expensive to analyze. But with hair, you can analyze up to about 6 centimeters of hair, which is each centimeter is about 1 month of hair growth. And so you basically can get a time series going back as far as 6 months, which is very cool. But as I said, it can be expensive. So if it's something that you're interested in getting as a potential outcome, the nice thing about hair is that rather than saliva, it is less noisy. So it sort of helps with power to have a measure that is less noisy. But also, if you are intending to use this as a mediation, to have less noise is actually important to reduce bias as well in a mediation analysis. So it's nice because it's objective, but I think there are still questions as to what exactly it's measuring. Okay, I think I'm up for time, so I'm going to hand over to Crick, who will continue the discussion. Thank you.
Thank you so much, Victoria. Crick, then over to you.
So once again, thank you so much for the opportunity. Really good to be with you and really great to be on this wonderful panel. I'm glad to follow Victoria because I think some of what I'll have to say will build on it. And I'm really coming from the perspective of those economists who might be interested in including mental health measures in their trials or in their surveys, but really don't have much of a background in mental health. So for those of you who do know a bit about this area, apologies if this is repeating some stuff that's sort of familiar to you. So I'm going to go through a kind of 3-step process, which I thought might be useful in making some decisions around this area. The first step is deciding what to measure if you're going to include mental health, perhaps as a secondary outcome or even a primary outcome in your trial, say of a behavioral economics intervention or a cash transfer program or whatever the case might be. I think the first decision, which is really important to consider, is whether you're measuring mental health as a dimensional construct or you're measuring mental illness or mental disorders. And these are not the same thing. These are some definitions which I put up here from some work that we did on the Lancet Commission on Global Mental Health and Sustainable Development. And here we define mental health as the capacity of thought, emotion, and behavior that enables every individual to realize their own potential in relation to their developmental stage, to cope with the normal stresses of life, to study or work productively and fruitfully, and to contribute to their community. So you can see here, we've tried to capture the notion of mental health as a dimensional construct. It's a capacity which exists on a continuum from mental well-being through to severe disability. It's very important when we're thinking about measurement, are we thinking about measuring this dimensional construct, or are we interested in the symptoms of a mental illness or mental disorder? And so this is the definition of mental disorders that we used in the Lancet Commission. That is disturbances of thought, emotion, behavior, and relationships with others that lead to substantial suffering and functional impairment in one or more major life activities, as identified in the major classification systems like the WHO International Classification of Diseases, or the DSM-5 is the latest version of the Diagnostic and Statistical Manual of Mental Disorders. So for me, this is the first kind of fork in the road where we need to decide if we're trying to measure mental health. And I want to try and unpack these concepts a little bit more, just to give you some sense of how we've approached this this work. So we've drawn a lot on the work of Patrick McGorry and colleagues in Australia who really pioneered this notion of staging in mental health. As I mentioned, it's a very much a dimensional approach, and it tries to characterize mental health on a continuum from the first stages, which might be asymptomatic, which probably is the case for the majority of a population, through to non-specific mental distress, which we all suffer from time to time, and then subsyndromal or sub-threshold symptom profiles. And then if this escalates further, a fully defined syndrome. And if it persists, then a recurrent persistent syndrome, and finally a treatment-resistant syndrome. And you can see what we try to capture in this diagram is how different symptoms cluster together to form a particular syndrome. For example, an anxiety syndrome, or a mood syndrome, or a psychosis syndrome. And I think what's really important to remember when trying to measure mental health is that it's not going to be any single thing. It's not going to be only a particular experience of mood, or it's not going to be only a particular set of behaviors or a particular set of cognitions. It's how these things cluster together and lead to significant suffering and functional impairment, all of those things together, which leads us to give a particular diagnosis, say, of an anxiety disorder or a mood disorder. And then also very important when considering this approach is that this is a kind of a convergence, and we're hoping as the field evolves, a convergence between fields of genetics and basic sciences and those of us who are involved in public health and anthropological and ethnographic methodologies. So really trying to pull together different disciplines to develop this more dimensional approach. And then very importantly, in this approach is a life course perspective, that these conditions are not equally distributed across the life course. There's certain peaks and troughs across the life course. For example, adolescence and early adulthood is really a peak when it comes to depression, anxiety, and substance use disorders. Whereas, of course, older age is a real peak for various dementias. And then also very importantly, when measuring all of these things, is consideration of gender, because there are marked differences in populations in presentations of mental health problems or mental disorders by gender. So once we've got a sense of what it is we're trying to measure, the next step is to try and select an appropriate instrument. And I'm glad Victoria mentioned this, because really for me, the next step is to consider, are you going to try and do a diagnosis, for example, using the ICD-11, and there's some quite well-known, well-established instruments like the SCID or the mini neuropsychiatric inventory, which will allow you to establish a diagnosis. Or are you going to use a screening instrument, which is generally a shorter instrument? It can be, in some cases, self-administered, or it can be administered by a lay field worker who's been trained. It's cheaper to administer, often much briefer, but perhaps less accurate than what we might call a gold standard, which would be a diagnosis conducted by a mental health specialist who is familiar with the local culture in which you're working. And I think that's incredibly important, because the way in which mental health symptoms present themselves is very strongly informed by culture and by local context. And then behind all of this, in terms of selecting an appropriate instrument, is this, for me, this really important question, which is which mental health condition, if you're focusing on a disorder, is most relevant for your research question. So, for example, do you believe that cash transfers at the household level will lead to a reduction in fear and anxiety related systems of the brain? And how do you think that would happen? Or would it be more influencing mood or depression related symptoms? So really thinking carefully about the mechanisms and how it relates to your intervention or your exposure is an important part of selecting an appropriate instrument. And then here are some considerations which I think are important to bear in mind when you're selecting an instrument. First of all, validity. Does it measure what you're hoping it will measure? And there are various different kinds of validity. There There's face validity, which is probably the most superficial, which is really at first glance, does it appear to measure what it is you're trying to measure? Then content validity, does the instrument cover all the relevant content? For example, will it check on all the symptoms that might be identified in a case of depression or anxiety within that local culture? Fourthly, construct validity, and we've done some work around this, for example, in the Affirm trial in Khayelitsha here in Cape Town. And this involves administering an instrument and then going back to the start of the instrument and asking your study participant what they understood each question was asking about and why they responded in the way that they did. So really trying to pick up a very rich, textured understanding of how the instrument is being interpreted and why people are responding in the way that they are. And then finally, there's criterion validity. Am I out of time?
2-minute warning.
2 minutes. Okay, thanks, Claudia. So criterion validity would be measuring your screening tool against a gold standard and coming up with an optimal cutoff point to determine maximum sensitivity and specificity of your screening tool. Then reliability is incredibly important. Does it measure what it sets out to measure in a way that's consistent, either consistent over time or consistent between different raters? And you can see in this diagram different visual depictions of reliability and validity. We want something obviously on the far right, which is both reliable and valid. And then finally, feasibility, and I think I can speak to this more during the Q&A session. Just before I finish, I wanted to mention that it's really also worth considering if you're working in a multidisciplinary team, adapting and validating screening instruments for local cultures. This is something that's really grown enormously in the last 15 years or so in global mental health research, and it requires some quite well-documented steps around formative ethnographic research, translation, back translation, and then careful validation and reliability testing. And here's an example of a nice study by Brandon Court and colleagues which did just this. So I'm now going to hand over to Miranda, and thanks very much again for the opportunity.
Thank you very much, Crick. Just a reminder to the audience that you can put all of your Q&A questions on the chat below. Miranda, the floor is yours.
Thank you. Thanks for those great presentations. So what you should be seeing now is a link to my LinkedIn post about what we're doing around harmonizing metrics. And it very much leads on from what Victoria and Crick were saying. And I guess I've got 3 things I want to emphasize in addition to what they've very helpfully said. And I'll say what those 3 things are, and then I'll explain why we've got to where we've got to. So the first thing is that not only are there no good measures in mental health, but the reason there are no good measures is we are not clear what we are trying to measure. So it's not fundamentally a measurement problem, it's fundamentally a conceptual problem. And I think if you need to grasp that when you are coming into this field. That's the first thing, and I'll explain a bit more what I mean by that. The second is, don't be seduced by experts in this area. I'm assuming I'm talking to economists, and there is a real mystique around mental health, that mental health professionals hold really specialist knowledge that's really hard to get and that you will not understand. Please, please bring to bear your most arrogant side in this and try and question absolutely everything about what you're measuring and why. And think at the level of the actual question. So I've put up here the actual questions that are included in all the measures that we're recommending. And it's the level of the item, it's the level of the question that you should be putting your energies and thoughts. And I'll explain why in a minute. And then the third is that I think the future of measurement will not be what it looks like now. So these measures were developed when they were written on pieces of paper, and you summed up the scores, and then you did all sorts of fancy statistics on that. The future will be adaptive testing. It will be a mixture of biological and behavioral and people reporting back, but it will not look like this. And we need to be planning for the future now, and particularly thinking in terms of item banks and adaptive testing for these sorts of questions. So those are 3 things, if you take nothing else from what I say, that I'd like you to take away. Where we are now, so I have the great privilege of leading a large funding program within Wellcome Trust. And I've been working with other funders trying to see how can we help the field become more coherent in relation to how we measure mental health. As I mentioned, there's a lot of uncertainty about what we even mean by depression and anxiety. So exactly as Victoria said, each way you measure these things is complicated and confused. And I would almost steer away from thinking there is a gold standard anywhere, whether you're interviewing someone or taking a hair sample or doing a screener. All of them are problematic because at base, there is no biomarker for depression or anxiety. There is no clear coherence as to what these things mean. And even if you look at the ICD or the DSM criteria, they are agreed by consensus by a bunch of people sitting in a room. There's no more magic to them than the screeners or to anything else that you might appear. So just hold that in mind when you're thinking about the measurement in this area. So in the light of that, what we've said is we want to find a common language for talking about mental health measurement. All the tools we have are flawed, all the concepts we have are flawed. We've come up with these measures because they are very widely used, all are free, and because they ask the sort of questions that we think are relevant to anxiety and depression. So they all relate to the sort of diagnostic categories. So they broadly ask, for example, about depression, whether people feel sad, whether they're having trouble in terms of sleep or eating, how they're coping with motivation and concentration. For anxiety, they're broadly asking about whether people are nervous or anxious or finding it difficult to relax or becoming very irritable. And then the same sort of questions for young people. And then we have one measure around impact in terms of functioning, which again is an area where I think we need better measures. And the idea is not that these are the only measures people use, but if you are doing research into anxiety and depression, we want you to use these measures so we have a common language across studies and can at least know that people are talking about the same things. But it's really important you capture these at the level of the items, the actual questions, and not just the sum score, because the sum score is an artifact created by consensus. Again, there's no magic about the borderline in these scores. It's often done based on norms of what percentage of the population, etc. So we really encourage you to use this, and indeed from Wellcome and National Institute and other funders that have signed up to this, we will not fund unless you use these, unless there's a very good reason why you wouldn't use that. Talking to Crick's really important point about adaptability, we do recognize that the need to be culturally sensitive is really crucial. And although these have been translated and are used widely, we are sure there are many cultural complexities that have yet to be looked through. So the way we see for the future is moving towards adaptive and item bank modeling, where what you would be able to do is pull down specific items, and you'll also be able to crosswalk across items and across measures to try and understand what these mean. So we need all of you who are involved in this area to be using these measures, but also to be learning from them, and as we adapt them, to learn what those adaptations mean in terms of the interpretation. So I think I will stop at that point and welcome questions and comments and join the other panelists.
Thank you very much, Miranda. I have some questions for all of you following up on your discussion. So the first question is for Victoria. Do you think that mental health gets the attention it deserves in economics? And if no, why do you think that is? And what needs to change for it to get the recognition it deserves in the years to come?
Thanks, Julia. That's a good question. So if you asked me 5 years ago, I definitely would have said, no, economists don't care at all about mental health. Nobody, some economists had written papers on them, but it was definitely not high priority. It didn't seem like it was high priority. But I think that's really changed. I think that there's mental health in everything now. There was a macro paper with mental health, modeling mental health and labor supply. I mean, that's crazy. So I don't know that it needs to change. I think the trajectory is on the right trajectory, which is that it's become part of really mainstream economics at this stage, or at least that's what it seems like to me, but maybe I'm definitely a little bit siloed in that space, but I think it's definitely, it's close to, to reaching what it needs to. I think there's still not as good of a conceptual sort of understanding of mental health and how it fits in within economics more broadly. I think that still needs to be, sort of worked on. It's still in the early stages, basically, but yeah. So great. It's good. It's promising, very promising.
Promising, good for us. And Crick, I have a question. I think you said that you also wanted to discuss a bit more about this in the discussion. So I believe that there's like several ethical issues that may arise when you're screening for depression or anxiety in your research studies, particularly when there's a severe case that is detected or when the resources to deal with the case are very scarce. So should the lack of resources stop researchers from screening for depression and anxiety? And if not, what steps should researchers take to deal with these ethical issues?
Yeah, thanks, Julia. I mean, it's a really important issue and important area. I definitely don't think we should avoid doing research in this area because we're worried about picking up high-risk cases. I think the high-risk cases are there, and the question is, how do we go about managing it? So I think it's really important that you build into your ethics protocol for your study design a very careful consideration of how you would manage high-risk cases that you pick up, whether it's suicidal ideation or suicidal behavior or intent. Or whether it's a severely depressed mood or severe anxiety or psychosis, whatever the case might be. And that you put in place not only a description of how you would identify these cases, but also what you would do to manage them and what the referral pathway would be, as well as reporting on adverse events, which you have, whether you have control over those adverse events or not. I think that's all really important basic practice. It might sound a bit daunting for economists who haven't worked in this area, but it's very doable. And I think it's certainly possible within low and middle income countries. We've done work in rural Ethiopia, in rural Kenya, where there are very few mental health specialists, but there's certainly ways of harnessing the existing primary healthcare system to make sure that those things work. So yeah, definitely worth doing and definitely worth planning for. Thanks.
Thanks, Crick. And for Miranda, I mean, you talked a little bit about it, but just a bit more to emphasize, why is really this work on harmonizing metrics so important, and what can we learn from it?
Well, at the moment, we have 280 different ways of measuring depression. That's not conducive to developing a field where we can learn from each other, because it means that in any given paper, you don't know whether you're comparing apples and oranges or oranges and pears or what. And especially in an area where there's so much conceptual uncertainty, we simply need to have a common language. Without it, we are in a Tower of Babel. So this is essential. But I think it's important in saying that we are not saying these are gold standard measures, these are wonderful measures. We are absolutely not. We're simply saying we need a common language. And that's a starting point, not an end point.
Great, thank you. I think we have quite a few questions. So I'm going to start off by the first. I think there was one question that was answered already in the chat by Jen. I don't know if Victoria wants to elaborate a little bit more about the hair measurement.
Thank you, Julia. Victoria answered in the chat. I was just wondering around ethnic hair, African ethnic hair, and if that also maps onto the measurements that she showed, but she said it works absolutely the same way, because I was just wondering, seeing as African ethnic hair that is a lot more coiled, if 1 centimeter would also be equal to 1 month. So that was something new to learn. So thank you so much, Victoria. My question that wasn't answered yet, I assume I can go ahead and ask that, Julia?
Yeah, go for it.
Okay, thank you. That was for Crick, and it's a really practical question, so I apologize if it's too simple, but I just wanted to know, with regards to some of the measurement screeners, for example, the SDQ, if I was interested in translating it for a Southern African country, Botswana, would it be sufficient to have 2 translators translated from English into the vernacular and then agree on that translation, then from that vernacular back into English and agree on that? Is that a sufficient level of rigor for translation? That was my question. Thank you so much.
Great, thanks for that really nice question. I think that's a really important first step, is to make sure there is forward translation and an independent blinded back translation. And what you do is you then compare your original English version with the version that's been translated back into English. So that's a really important part of the process. And exactly as you say, to have independent people doing that, which is really great. If possible, it's really worth establishing a small group or small committee to actually work through the process together and to discuss each term, so that you really have different perspectives. Sometimes you can get people involved in translation who do very sophisticated translations, but might not necessarily reflect the local vernacular and the local terms that are used. So I think that's really, really important. And then also really important to have a look and try and understand the idioms of distress that are signified by the particular word. So terms like kufungwisisa or ucinga kakhulu, means thinking too much, but how does that translate into what we think of as depression? So again, going back to Miranda's point, understanding the construct and the constellation of these different symptoms is really important in the translation process. You can't separate it out from that. So I hope that helps. Thanks.
Thanks, Crick. Now we're going on to Vincent Thorne from Trinity College Dublin.
Hi, thanks for the great presentations. I had my first question was about, you made this distinction, right, between screening and diagnosis tools, right? And I was wondering, when would we prefer then a screening instrument? Would it be because of cost or time? And what could we do with these outcomes that we'll be measuring if they're not as reliable as diagnosis?
Was that for me or Miranda or Victoria?
I think that it was Victoria that mentioned it. I've got something to say about it, but I'll let Victoria answer first, and then I'm happy to chip in.
Sure. Yeah, I think it depends. So, in terms of what you want to use, it's a matter of like what capacity you have. The screeners are a lot easier, but then once you analyze the data, you can analyze, all of the questions individually. You can analyze the total score. A lot of the screeners, for example, the PHQ-9 gives you like symptom severity. So you can analyze it as symptom severity. You can do the cutoff and say, this is the impact of this intervention on, the risk of depression. But it's just a matter of, how you interpret that outcome. It is slightly different than how you would with a clinical diagnosis. I guess you would just, those are slightly different things. So you just want to be sure that you're distinguishing between them more. I found in my own research that the clinical diagnoses seem to be, less noisy than the screeners in the data. And so there's a trade-off because, if you have a large trial, maybe you don't care that much about the noise, but if you have a smaller sample size, then you start to care a lot more about the noise. And so you might prefer to do the diagnosis if you can. But in any case, when you do the diagnosis, you might also do the PHQ-9, for example, because it doesn't really take much time. So you end up having both. But I think that's all I have to say on that. So I'll let Miranda chip in.
Thank you. Yeah, no, I think you put it really well. I think it's what you want. I suppose the two things I'd add is, if you're being funded by one of the funders involved in our initiative, we would say you need to use the screener as well. So that's the first thing. Although you can use a very shortened version, depending on what suits you. The second thing is I'd just be cautious. The issue of diagnosis in mental health is complicated and it's not particularly reliable or necessarily valid. So just be aware that it may be less noisy, but it may have other problems with it as well. So just because one's more expensive and takes more people doesn't make it better necessarily. It may be better in some ways, but it may be worse in others. So just be aware all these things have got pros and cons to them. I think it's just very important not to see them as that they're all on some sort of scale of what's good and what's bad.
Thank you both. We're now going to Peter Seniors from the University of East Anglia.
Thanks very much for presentations. So question to Miranda, given that you're in this work of, having an overview of what is being used and working towards a new instrument, what would you suggest for COVID surveys or surveys given the COVID situation, which is of course a much shorter questionnaire very often that is being used. So do you have, I guess, two questions. One is, do you have a view of already widely used instruments, widely used across settings that are useful for comparison? And then two is whether you are working towards an instrument for telephone surveys as well. Thanks.
Yes, it would be the same instrument. So there is a network called COVID Minds, which is run by Daisy Fancourt out of UCL, but includes a collaboration of all those doing longitudinal studies around mental health and COVID internationally. And they are using shortened versions of the PHQ and the GAD, which were the two measures that I showed you in the overview. That you can. There are two item versions of those measures that you can use that are incredibly short and actually not particularly worse than the longer ones. There are 2-item, 4-item, 10-item. There are a whole range of ones. So yes, we would recommend you use those.
Fantastic, thanks.
Thank you, Miranda. Now we're going to Sara Mansour from the Blavatnik School of Government.
Thanks, Julia, and thanks to all the speakers for this really interesting set of presentations. So my question was for Miranda, and I'm sorry, I'm very new to this area and still learning about mental health measurement. I was just wondering that if for children we are interested in capturing both anxiety and depression separately, to what extent would we need to adapt the PHQ-9 and the GAD? And I was just curious if, Miranda, you've done this before in your work on early childhood development and child research. Thank you.
So the third column on the diagram I showed you, that's a measure called the Revised Child Anxiety and Depression Scale. So you would use that instead of the PHQ or the GAD, and that covers both anxiety and depression. So those questions in that third column that I showed you, those were the ones you should use.
But that should give me a combined measure, right?
It can give you either separate or combined.
Oh, okay.
So you can use, it has a set of subscales, and you can use the ones that are specific to anxiety or the ones that are specific to depression, or you can use them combined. It's whatever you...
Okay, great. That was my question. So great, thanks.
No problem.
Thank you, Sarah. Thank you, Miranda. We're now going to Rosanna from Oxford Brookes University. This is a technical question to the panel. When using something like GAD-7 in regression analysis, do you recommend using the total score or transforming it to linear scale? So develop a set score of each individual item and then taking the averages.
I wonder if Crick or Victoria want to have a first go on that. And again,
I can have a first go. I'd be interested to hear what others think. I mean, I think it's probably worth doing both if you can, and doing some kind of sensitivity analysis. I often see a sort of an analogous way of trying to approach measuring screening tools or analyzing screening tools, that we use a continuous score and a categorical score with a cutoff, which has been predetermined. So, you can either measure your outcome as a continuous variable and do linear regression analyses, or you can measure it as a categorical measure and you do a logistic regression. But I think it's sometimes worth doing both because there can be information lost, for example, in the categorical or dichotomous approach. Thanks.
Victoria, do you want to chip in or?
No, I think I completely agree with what Crick said. Yeah.
Great.
The only thing I'd like to chip in to say is that there's a really interesting psychologist working in this area called Eiko Fried, who in fact has very much challenged our way of harmonizing metrics, but has really interesting ideas about how to use T-scores and other sorts of normalization as a way of harmonizing metrics. He's just published a paper with a colleague on this just a few days ago. If I knew how to, I can't put it into the chat, but I'll send it to the organizers, and I would really encourage those who are interested in this to be looking at his work, because I think it's at the cutting edge of the measurement spectrum and how to use measures, particularly in terms of network analysis and item response theory.
Great, thanks, Miranda. We'll make sure we share that around. Next question is from Alan Stein from the University of Oxford.
Thanks very much, panel. Really excellent presentations. I was just wondering, in a sense, there's a kind of a call to arms here to have economists more involved in mental health research. I know many of them are already. I just wondered what you thought their unique skills or what unique contribution they could make to this, other than just joining the measurement. I mean, work that, for example, things like decision-making expertise. They have a whole range of expertise that might be brought to bear here. I just wondered what you might recommend, or how you could encourage them to be more involved in this using their expertise.
Crick, you want to go?
Yeah, I mean, I'm enjoying hanging out with economists more and more as the years go on. So I think there's lots of potential, Some ideas, Alan, I mean, you alluded to one, which is really, I think there's a whole huge amount of rich theory around behavioral economics, which I think can really enhance the way we understand things from a kind of clinical psychology or clinical psychiatry perspective. So that's one really important contribution. I think secondly, on measuring the economic impacts of mental health interventions, and we've got a review on this at the moment that we're trying to get finalized, but we found really significant economic impacts of mental health interventions. And these are mainly mental health trials with primary mental health outcomes, but they just happen to include a secondary economics outcome measure. And it's been absolutely fascinating, really trying to make sense of this data, but I think that's a really huge component. Something that I've said a lot to mental health colleagues is please consider including economic outcomes in the trials that you do. So those are just two immediate ideas, Alan. I'm sure others have more.
Victoria or Miranda?
I think just to build on, I think both those sound great. I think certainly from Wellcome's point of view, any ideas economists have got about what are the economic measures will be in our core set as we develop it further over time, that would be brilliant. We have this phrase we use at Wellcome, which is we're trying to create a world in which no one is held back by mental health problems. Operationalizing what is meant by held back, whether it is in terms of physical or economic or other metrics, we're really interested in. So any creative ideas you have or any measures that you may be aware of that we should be thinking about embedding as core, we'd be very interested to hear.
Yeah, and I would say that one of the really interesting things that I guess economists bring to the table is perhaps, looking at interventions that are not necessarily, sort of mental health interventions or treatments that are specifically targeted at mental health, improving mental health or treating mental disorders. And so a number of colleagues who are here on this chat, in the chat, have done a lot of work, for example, evaluating cash transfer programs and so on, other types of interventions that have substantial impacts on mental health. And I guess then doing cost benefit analysis, for the sake of, sort of policy and thinking about what, how do we best, alleviate poverty? We need to understand, where our dollars are best spent. And, a lot of mental health interventions are really, really expensive. And so maybe it's easier to provide, cash transfers to people and then only escalate to mental health interventions for subsets of individuals, sort of various stepped care, but, the first stage being not necessarily sort of a clinical thing. So I think that that's something, sort of thinking a little bit outside of the box of mental health, I think is just valuable in this case. And so I think that's really interesting to see how those interventions compare across the various types in terms of the value for money.
Thanks very much.
Thank you very much, all of you, for that answer. So we're now going to go to Johannes Halschoffer from Stockholm University.
Hi, everyone. Can I be heard?
Yeah.
Great. So this is a question, I think, for all three panelists, perhaps especially for Miranda and Crick. So I'd be curious to hear your thoughts on how gold standards become gold standards, both de facto and how we think that should happen. I've heard Miranda talk about how we have to reconceptualize our understanding of many disorders. And as soon as we have that done, I imagine that would lead to new gold standards for measuring them. And I've always been a bit confused about how that happens before we develop the scales that then sort of approximate the gold standard. So it'd be great to hear your thoughts on that.
Shall I start and then Crick come in? And I think there may be really healthy and appropriate differences of view between Crick and I on this, so I'd be really interested to hear them. So from my point of view, where we are, particularly with anxiety and depression, it may be different for other mental health disorders. So if I just stick with anxiety and depression for the moment, I think we have to move away from the idea that there is an underlying thing that we are measuring to saying there are things that we are measuring that lead to people not living the lives they want to lead, and that those things that we are measuring may be the level at which we need to think. So those items about whether you are sleeping, whether you are feeling sad all the time, whether you're feeling like you can't get out of bed in the morning, those are the things we need to know. We don't need to sort of imagine there's some concrete entity underneath it, because there's a tautology in the conceptual underpinning at the moment. So even calling them symptoms is a misnomer, because symptoms of what? They're only symptoms of themselves. So if you just think of the items as facts about people's life experiences, then I think that's where we move to a gold standard about how do you measure the life experiences and behaviors and thoughts that we need to know about in order that people will not be held back.
Mm-hmm.
So that for me, so I think getting away from the idea there is an entity there that there's a gold standard about is probably the first step to that, but that is not the view of everyone that I very much respect. So there may be differences of view on this.
Right.
Yeah, thanks. I mean, I do agree with Miranda. I do think that this notion of what is a gold standard is shifting all the time, and I think there's a long history to this work. You know, traditionally there's been a distinction between what we call emic and etic approaches, and you know, the etic was the traditional universalist approach, which is there is one notion of depression which underlies all these differing cultural manifestations, but actually there is this core entity. And then the emic approach is much more that it's actually incredibly diverse human experience of emotional and cognitive suffering, or suffering related to how the brain functions, and that we can't come up with comparable measures. And I think it's really important that this debate continues over time, that as we try and develop more common and shared measures, what I think is incredibly important from a global mental health perspective, we also pay close attention to local experiences of functional impairment and suffering, and those are often expressed in very diverse cultural ways. So I think, you know, this is really something that we need to continue to interrogate. I really agree with Miranda's approach, which is to look at items themselves and look at how they coalesce or cluster around particular syndromes, and then to see how these are linked to exactly holding people back, impairing their functioning, their ability to pursue the lives that they choose to pursue. So for me, if we can maintain that underlying approach, then, you know, I think we can moving somewhere, hopefully, forward.
Great, thank you.
Thank you very much. And the last question, because I'm aware we're running out of time, is Frank Schulbeck from MIT.
Thanks so much for this terrific session. So one question I have broadly is about, how do we get economists to understand or acknowledge that mental health outcomes, you know, measures of, say, depression and anxiety, are important bind in themselves, as opposed to maybe sort of instruments to improve or increase consumption or reduce poverty or the like, which, you know, economists obviously care about. So I wonder whether you have any thoughts on how to get economists and donors more broadly to sort of realize that these outcomes are important bind in themselves.
I could have a go, but I'm really talking too much. Should I have a go and then others chip in?
Yeah, go for it.
Yeah. So, I mean, I think, you know, Amartya Sen's approach of freedom being both a means and an end to human development is quite an important or useful analogy here. I think mental health is both a means, but also an end of human development. And, you know, I think it's important that we look at it as in an instrumental way. We say, you know, what are the economic benefits associated with better mental health? But I think fundamentally people have a right to better mental health, and we should be addressing the massive inequalities globally and within countries in people's overall mental health and well-being. And often these are strongly socially determined by adversity, by poverty, circumstances of civil conflict, natural disasters, and so on. So I think it's really important that we think about mental health as a goal. I think it's a very worthy goal in its own right. So I hope that helps, Frank.
Okay, I think Victoria, I see that you wanted to go to unmute yourself.
No, I just wanted to say, I think that what Crick said was spot on in terms of evaluating sort of the welfare of a group of people. I think, you know, so far economists have really focused on the sort of what is the productive capacity of mental health, you know, how does it affect decision making, productivity, and so forth, and like that's why we care about it, which of course we care about that because, you know, the potential for poverty traps. And so if there is that going on, then we really think that we should be investing in, you know, in mental health type improvements to mental health. But I guess, you know, exactly what Crick said, that, you know, it is also an end in its own, because it is a measure of welfare. And I think that, you know, sort of economists tend to just focus on, I guess, income and they tend to, for welfare measures, they do tend to focus on income as the primary one. And I don't know how we get ourselves out of that hole. So that's a question for a bunch of economists that are more senior than me, I guess. But
thank you, Victoria. So I just wanted to thank all of you for being here, and sorry for those that asked the questions that we didn't get to. I am aware that we're running out of time. And I'm now going to hand it over to Kate Orkin, the director of the Mind and Behavior Research Group, to say the final words. Thank you, everyone.
So I just wanted to say thanks again to all of the panelists on our behalf. I mean, to Victoria, who's up late at night, and then also Crick and Miranda have been enormously patient as we kind of build this movement in our discipline at explaining things to us kindly. I think every time we sit in these sessions, people you can just see their sort of light bulbs going off as we get a much bigger perspective on the things that we're trying to integrate in. So thank you. You can see this is, we had a peak 117 participants on this session. We were a little bit worried this was going to be a fringe session for the conference, but it's ended up being one of the biggest ones. So you can see how much things are, you're really encouraging something that's, I think, building a lot of momentum in our discipline. And then finally, just to thank Samir, Cara, Julia, and Lucas Hensel, who've been organizing this from the group's perspective. It's been a lot of work to pull together, and we really appreciate the work that you guys have done.
Thank you very much, Kate. Thank you all for joining us, and hope to see you at the next event. Bye.